morning, Chair. Your meeting is now live.
Good morning and welcome to the Primary Care Commissioning Committee meeting. I'm Margaret Geary, lay member. I will be chairing the meeting today. We are meeting virtually in response to the limitations placed on governance by the COVID-19 pandemic. Members of the public have been invited to view this meeting via a link available from the NHS Portsmouth Clinical Commissioning Group website, and papers for the meeting are also available via this website. Today's meeting is being recorded so that in the event of a failure of technology, it can continue and will then be uploaded onto the NHS Portsmouth Clinical Commissioning Group website as soon as possible. Committee members and attendees are requested to keep their microphones on mute and only to turn them on when they're called to speak. Please use a raised hand to indicate that you wish to speak. Please can I ask everyone taking part today to confirm that they are present. Before I do that, can I just say that we've had several apologies today. Helen Atkinson, the apologies are from Helen Atkinson, Michelle Spandley, no, Dr. Claire Siever, sorry, Michelle should be here, Nicola Burnett, Johan Svensi, and Sylvia Macy, Justina Jeffs, and Andy Sylvester. So when I call your name, can you turn on your microphones and give your name and title? So, Jason Eastman.
Good morning, Margaret. I'm Associate Director of IT.
Mark Compton. Is Mark on the call?
Apologies, Margaret. No, Mark's not on the call today.
Okay. Simon Cooper.
Simon Cooper, Director of Primary Care, Portsmouth CCG.
Julia O'Mara.
Good morning, Margaret. Julia O'Mara, Practice Nurse Advisor, Portsmouth CCG.
Dr. Nick Moore.
Yeah, I'm Nick Moore. I'm a GP, Clinical Executive on Portsmouth CCG.
Jackie Powell.
Good morning, Jackie Powell, lay member.
David Scarborough.
Good morning, David Scarborough. I'm the Practice Manager Representative for Portsmouth CCG.
Michelle Spanley.
Hi, I'm Michelle Spanley. I'm Chief Finance Officer for the CCG.
Jo York.
Hi, I'm Jo York. I'm Deputy Chief Officer for Health and Care Portsmouth, CCG and the Council.
Roger Batterbury.
Hello, I'm Roger Batterbury, Chairperson at Health Watch Portsmouth.
Claire Curry.
Hi there, I'm Claire Curry, Consultant in Public Health, Portsmouth City Council, and standing in today for Helen Atkinson, who sends her apologies. And just to note, I'm going to need to leave at 11 AM, unfortunately.
Lisa Harding. No. Is Lisa here? No. Christine Horan.
Morning, Chris Horan, Primary Care Improvement Manager.
Steve McGuinness.
Morning, Steve McGuinness, Head of Primary Care Commissioning.
Stephen Arobia.
Hi there, Stephen Arobia, Clinical Quality Manager, Portsmouth CCG.
Rebecca Spanley.
Good morning, yes, Rebecca Spanley, Finance Manager for Portsmouth CCG.
Carol Giles.
Good morning, Carol Giles, Senior Commissioning Manager for NHS England.
And Lisa Stray.
Yeah, Lisa Stray, Executive Assistant for Business Services. And may I just introduce Andrea Edson, who's on the call from Finance.
Thank you. Thanks, Lisa. Okay, can I then move to any conflicts of interest or any additional interest that you want to register on the register? Are there any conflicts of interest to just declare? Nick?
Yes, Nick Moore, as a GP working in the city, I have a conflict of interest to declare, I think, on the item related to particularly the sequin. I think it's a final agenda item.
Yeah, okay, but it's an indirect interest. So, yeah, okay. Any others? Dave?
Yeah, Yeah, hi Margaret. Obviously, in usual course for these meetings, as a business manager for GP practice, I've got a number of conflicts of interest this morning, in particularly the GP surgery website, and the same as Nick with regards to the sequin.
Okay. Again, those are mostly indirect interests, are they? Can you confirm that?
Yeah, that's fine. Yeah, thank you.
Okay, so you can still take part in the discussion. Thank you. Can we then move to the minutes of the last meeting? Can we look at it for accuracy? Page 1, page 2, page 3, page 4, page 5, page 6. I've got a hand up.
I had my hand up. Sorry, Margaret, for a small typo on page 3 under the primary care finance report. I think it should be amended for 2021. It's just a small typo. It says 21-21.
Ah, okay.
And before that, I think I saw Sylvia's hand raised as well as Tina's.
Sorry.
Nipped in ahead of them. Thank you.
Okay.
Sorry, Margaret, I am here. I had a meeting cancelled, so although you got my apologies, I'm actually still here. Sylvia Macy, Primary Care Estates Programme Manager.
Yeah, I think I was told that, so I'm sorry about that, Sylvia. I should have registered that. Thank you. Anyone else got their hand up? No, can't see any. Right. Okay. Can I then keep going? Page 5, page 6, page 7. Okay. Can we then go back to the actions that were generated last time? One was to ensure that Dr. Nick Moore was added to the Declaration of Interest Register, and I believe that's happened. Yes, Nick's nodding. And then the Hampshire Isle of Wight Digital Primary Care Roadmap update. Jason.
Thanks, Margaret. Not really a lot to add, except we're still just waiting for the final sign-off from the regional team, which we believe is imminent. But there is one bit of good news. We actually have Hampshire and Isle of Wight have been successful in obtaining funding to continue or extend a pilot of digitising the Lloyd George notes within practices. So we are aiming to extend that pilot to at least include one practice from every CCG area in the Hampshire and Isle of Wight footprint.
Okay. Any comments on that? No. Okay. Can we then move to the risk register? And Steve.
Yeah, so this is obviously one of the agenda items, Margaret, so we can come on to speak a bit more about this later if that's okay. But we have made some progress around the PCSE issues, and I think in terms of the wider review of the register, I think we've probably still got a bit more work to do around that. Obviously, we've been very busy around the COVID vaccination programme, so we probably still need to revisit the risk register over the next couple of weeks.
Okay. People content with that? And that'll come back when? Steve, do you know?
Well, we can obviously report back at the next committee meeting on any updates to the register that have taken place.
Jackie, and then Dave.
It was just a very quick one, Steve, with regard to the COVID-19 risk, about pressures on practices. We haven't actually noted down a number in terms of what the current risk is. And I don't know if that's deliberate or whether, you know, is it the same as it was originally, or do we feel that we've lowered that a little bit?
Should we deal with that when we get to the item on the agenda?
Yeah, sure, of course.
Okay. Yeah.
I just want, if it was a typo, it would be a quick fix, that's all. Thank you.
Dave?
Thanks, Margaret. Yeah, I'm sure I know what Steve's answer is going to be to this. I just wanted to sort of confirm that when the risk register comes back, the recent survey is done of practice managers for the service from Primary Care Support England will be reflected in that.
Absolutely, Dave. Yeah, that was the idea behind that. Yeah.
Okay. All right. Thank you.
Thank you. Any other questions? We have to move then to the next item on the agenda, which is the finance report. And that's Rebecca.
Yes, thank you, Margaret, and good morning, everyone. So just a couple of points to note on the finance report that's been brought to committee today. So this is the financial position for the primary care budgets as at month 9. So a couple of points which I think were mentioned in the previous meeting by Nikki Burnett, so just to sort of reiterate those points as well. The main benefit that we're seeing in primary care at the minute is because we have a contingency built into our delegated commissioning budgets, which we haven't needed to utilise in year. So that's around risks that arise in year. The CCG has also been working hard to review forecasts to give an accurate picture for year end. And so in the main, we've revisited the forecast for our maternity and sickness locum cover. And that's just to reflect that there have been less applications for this funding in year than was anticipated initially. As noted by Nikki in the last committee meeting, our locally commissioned schemes will be income protected this year, just to support GP practices with the delivery of new priorities, given the common circumstances that the pandemic has put upon us. And this also applies to some QOF indicators and also the minor surgery directed enhanced service as well. The CCG has now also received its share of the COVID Capacity Expansion Fund, which has been committed in full to our GP practices, and our practices will be working to achieve 7 priority areas, all linked to the pandemic. And we've also received in month 9 some GP Forward View funding, which will also be committed in 2021 to the relevant schemes. So they were the sort of main points from the finance report this month. I'm happy to take any questions if anyone has any.
Are there any questions or comments? No? Shall we? Oh, Dave, sorry.
Just briefly, please, Rebecca. With regards to the COVID Capacity Expansion Fund, my interpretation of the guidance that came out with it is that you will not be looking in any great detail for how practices have spent that money. Can you confirm what practices should expect in terms of having to sort of report back where that money's gone?
I believe there is a reporting mechanism with regards to those 7 priority areas. I might look to Steve in case there is any more that Steve can add. Yes, got his hand up.
Yeah, from my point of view, Dave, the message that we've had kind of from the centre is that it's fairly light touch, but some form of monitoring would certainly be in order to see how practices have used that money. So no doubt there'll be a template of some sort coming out in the near future so we can get a bit of a handle on how that money has been utilised.
Okay, all right, thank you.
Thank you.
Okay. Any other questions? Jackie?
Thank you. I just wanted to ask about the collaborative fees, because there seems to be quite an underspend on that. I understand about the additional roles reimbursement scheme. I think that was explained before that we may not be able to spend it in the way that NHS England wishes, so it's hard to actually allocate. That bit I get. But I didn't quite understand the difference with the PMS premium reinvestment as well. So it's those two things, the collaborative fees and the PMS premium reinvestment.
Yep, of course. So the collaborative fees that is a service hosted for the Wessex patch by NHS Southampton CCG, so on behalf of our area, and that's all relating to, in the main, assessments for Mental Health Act, health. Sorry, I've lost my words there.
Okay, so
no, that's fine. No, it's Mental Health Act assessments and adoption assessments as well, in the main. That's what that covers. So they deal with reimbursements for those costs, and then we get recharged by Southampton CCG. So the forecast is just a reflection of the charges that we've seen in year, and therefore just a reflection of the activity that we've seen this year across the patch. And then the PMS premium reinvestment, so that's just in there to note that this year is the final year of the sort of reinvestment monies, so the end of the 5 years of the PMS reinvestment. We're keeping track of how that's been reinvested across the 5 years when that was sort of first initiated, and that's just to reflect that there is an amount of investment in there that we haven't been able to invest in year, just due to the current situation with the pandemic. But what we'll be looking to do is include that within financial planning for next year to ensure that we ensure that that is invested recurrently in future years.
That's perfect. That's perfect. Thank you. That made sense. Thank you.
Any other questions, comments? Carol?
Yes, please. I'm sure you're on top of this already, but obviously as the PMS money has been invested, of course, it's a result of funding being taken away from those PMS practices. Presumably the CCG is monitoring the impact of that on the practices affected.
I was going to say if Steve.
Probably Steve would know the answer.
Well, yeah, I'm just going to come in anyway at some point, Carol, thanks. Just to say, we've reinvested a lot of the PMS money already, of course, back into general practice. And at next month's committee, we'll be bringing some proposals to utilise the remaining money that we've got. So we've got a few proposals that we can make next month.
Yeah. Thank you.
Thank you, Steve.
Okay. Any other questions, comments? Happy to note it's the month 9 position. Yes, Steve. Your hand up?
Just to say, Margaret, earlier we were doing I think we were doing the actions from last time around the risk register, but we've kind of jumped past that item on the agenda. Would we be okay to go back to that now?
Ah, right. I think I had moved to the risk register item, I think, and yes, because it wasn't an action from last time. Okay, we can go back to the risk register. And Steve, do you want to make some comments on that?
Yes, yeah, thanks. So there were a couple of actions from last time. One of them was relating to Primary Care Support England. And on that one, we have surveyed our practices around what issues they're experiencing and how they kind of rate the current service. And the feedback around that was very negative overall. Lots of issues that practices are reporting. So it still really is quite a big issue that practices are facing. I've just sort of collated that in the last few days and shared that with Carol and her colleagues at NHS England. And then obviously we'll see whether we can take that forward with PCSE. In terms of the actual register itself, when we come to review that formally over the next couple of weeks, we can see whether that risk score needs to be amended at all. Quite possibly might need to come up a notch. But in terms of all the other items on the risk register, no changes at the current time. Haven't had any feedback from other colleagues in the CCG yet about any proposed changes. But as I say, as time allows over the next couple of weeks, we'll review it a bit more formally. And I know that Sylvia is going to take on some responsibility for that risk register, which would be really helpful. I'm not saying that Sylvia's got lots of time on her hands, because she certainly hasn't with all her estates work, but obviously we've struggled to put a lot of time into it lately due to the vaccination programme.
Thanks, Steve, and apologies for my confusion. Thank you. Carol?
Yeah, just to follow up on Steve's comments on PCSE, I know that Johannes Wenzel has sent a chaser to PCSE again this morning, particularly around the issue with the pensions that has been causing a lot of difficulties. I will also escalate to my head of primary care and see if we've got any other way of pressurising them. It is very frustrating, I know, for all of us.
Thanks, Carol.
Jack, Dave?
Just on that, Carol, with the pensions from a practice perspective,
Yeah.
PCSE are just not replying.
No, it's really frustrating, I know.
Yeah, I raised some very significant issues with them last month, which was on the back of problems throughout the year and silence. And it's just as of a note, really, I'm not expecting any pearls of wisdom from you because I know how difficult it is, but just to highlight the point.
No, thank you. And Joe had shared that with me. I know it's totally unacceptable, and we are pursuing it as hard as we can. It's just we're just going to have to keep on top of them until they sort it, I think. I know it's not good. It's a shame because they seem to improve for a bit, but they've gone downhill again now.
Steve, do you want to come back on that?
Yeah, just to pick up really on Jackie's query around the COVID pressures, we can consider, as I say, over the next couple of weeks, we'll consider whether that scoring needs to be amended. But whilst we do have the occasional, resilience issue within a practice due to sickness and other issues, I think overall practices are mitigating against all those resilience issues. And managing to deliver the services they need to, including obviously the vaccination programme. So unless other colleagues over the next couple of weeks, including people like Dave, feel that that needs to be changed, I think practices are managing to just about cope with things.
Nick?
Yeah, just to add to that, really, obviously some of the income protection element, and also some of the stuff which is from Sequin, which is being kind of sort of stood down as part of sort of COVID responses, I think is also helping sort of give a bit of extra capacity in practices, just to sort of inform the discussion of that, really.
Okay.
That sounds really good, and I've seen and heard how hard primary care has been working and how well they've responded. So for my question was like, generally, was there just a number missing in the current risk score, or whether we're teasing that out? So it sounds like it's going to either maintain at a 12 or maybe even go lower from the way that primary care has responded.
Steve, do you want to come back? Put your hands up.
Oh, sorry, Mum.
Okay. Any other comments, questions? Can we note those actions then? Thank you. And thanks for dragging us back, Steve. Can we then move to the approved chair's action for the standard operating procedures? Simon, do you want to explain this? I know that Jackie did sign these off as deputy chair.
I'm happy to go through it, Margaret. So this was the procedure that went through in the early days of the standing up of the vaccination programme, where the standard operating procedures, particularly for the first vaccine that became available, the Pfizer-BioNTech, that needed very particular reconstitution, and we were required to put standard operating procedures in place. The Specialised Pharmacy Services created a suite of standard operating procedures to everybody to act under, but they're required to go through each accountable organisation's standard procedures and ratification process. In order to get these ready and approved prior to the first go-live date of our vaccination, PCM vaccination centres, we had to take this outside of the meeting and take chair's action. So the process was that, as the senior pharmacist for the organisation, I reviewed those standard operating procedures and made Nick more aware of those standard operating procedures, and then we took chair's action outside, which at the time was through Jackie Pale as deputy chair. There are some minor updates, and as we go on, I suspect there will be more and more standard operating procedures coming out, but the process will be the same in terms of adopting them. They are nationally reviewed, peer-reviewed documents, and are always incredibly well written and fit for purpose. So I have no qualms at all in adopting them for our processes.
Any comments on that? Okay, just note that the chair's action then, please. Okay, can we then move to primary care audit reports? Steve?
Sorry, Mark, can I just ask one question of Simon on relation to that in terms of the standing operating procedures? Will there then need to be these coming back to PCCC, or will we just kind of deal with these outside? Because obviously we did review these at some pace when they had to be looked at, and what will be the process for them going through, you know, for being adopted again, given the fact that they've obviously been through a process outside of all of this?
Yeah, I did talk to Justina briefly about that process and how we handle that, and I think I need to bottom that out exactly, because there is the potential for these to be adopted and changed, etc., on a incredibly frequent basis, and how we can actually adopt these and take these forward as a process without ensuring. So we need to ensure that they've gone through a governance process and we're happy for them to work, but also we need to be able to react agilely and update procedures. I'm not sure how we square that circle off yet, but I need to just touch base with Justina again to make sure we've got that signed off as whatever that process will be.
Yeah, because as you say, they do often change quite quickly, particularly with doses and transportation. We've got another one that's been approved today, so we'll have our fourth one potentially, won't we?
Yeah. Thanks, Nick. Yeah.
That's clearly very helpful.
Yeah. To be fair, the SPS are keeping these under review and doing them for us, which is more helpful than us trying to create them all ourselves at last minute. So it is incredibly helpful from that point of view. And what is slightly frustrating is the necessary detailed changes that need to come through.
But as a GP with the prescribing lead, happy to liaise with Simon and do stuff outside of this if that's the process, so that we're not having to keep on going backwards and forwards and bringing things here if it's unnecessary. And you know, obviously with this meeting only being every 2 months.
Yeah.
Thanks. That sounds like it would be necessary. Thank you very much. Okay. Can I then move to the primary care audit report? There's no other questions. Thank you. Steve.
Thanks, Margaret. Yeah, I just thought it was worth sharing our report we got from the internal auditors. This was around our commissioning and procurement services. And we received substantial assurance, which is the highest rating, which was really positive. I think that reflects quite well on the primary care team and also our colleagues in the finance team who work closely with us around commissioning, and also on the practices themselves who have to comply with all the regulations and the contractual requirements, and they're part of the process as well. So we were advised that we had effective controls in place for all our commissioning of services, which was, as I say, really positive. A few minor findings which we take on board around, we haven't published our primary care strategy on the website, so I think we put that right, and they suggested we could enhance our procurement strategy. And they shared an example document for us to look at, but of course we do link up with our commissioning support unit on all procurement issues anyway, so we'll continue to do that. But overall, really positive. I think irrigation was a good example of a service that we commissioned where we've done some good groundwork around that one. So we worked closely with the local medical committee on that service, which was a new service that we commissioned last year. We involved our CCG nurse advisor, Julia, in a lot of that. Listened to some feedback from practices as well, and also informally from patients as well. We'd had informal feedback from some patients around the lack of service provision and difficulties in obtaining that service. So, and of course we then took it through committee, so we had people such as Health Watch, Portsmouth able to have their say as well. So we'll continue to do that. One thing I think we would like to enhance further is that patient involvement, and probably do a bit more on that. We certainly did a lot of it several years ago when we first started commissioning some of these services and did lots of patient surveys, etc. And whilst we do sort of listen to any feedback we get, we can probably enhance that further as we go forward. But just wanted to share that report really, which reflects well on the CCG.
Okay, yes, it's a good report. Carol?
Yeah, just really wanted to congratulate the primary care team on that. I know it's the result of a lot of hard work, so just want to recognise that from NHS England's point of view. Just on, obviously you mentioned the patient engagement. Would you say there's anything further, any further learning from that? Not that I'm saying there should be, but was there anything further that gave you second thought around or anything?
There was nothing raised by the audit team, to be honest.
Sometimes the process makes you think about it, though, doesn't it?
Yeah, it's just something always on your mind to think, you
Yeah.
know, what more can we do around patient involvement? So I think it's something when we get a little bit more time, we'll look at further, definitely.
Okay, thank you.
Thank you. Okay. Can we then move forward? Carol, you've still got your hands up, sorry. Thank you. Move forward then, note that report and congratulate the team on all of that. Can we move to the Health Watch Portsmouth report? Roger.
Oh, thank you, Margaret. Yes, so Health Watch Portsmouth did a desktop review of GPs' websites. It's attached in the agenda. So the idea was to identify information that could or couldn't be found on each GP website, gather feedback on the patient experience of using GP practice websites with our volunteers and staff team, and then share the information and make recommendations. So there were some interesting findings. I think the one that stands out for me is the 75% of website visits GP surgeries across the city stated they require 2 forms of identification, whereas the guidance says that there's no regulatory requirement to prove identity, address, immigration status, or provide an NHS number. And the other findings are in there. I guess, you know, we've made recommendations, and, you know, it would be nice to see some of this tidied up. It's just a very interesting process to go through, probably overdue, and it's something we're going to repeat. So happy to take any questions.
Steve.
Yeah, thanks, Margaret. Thanks, Roger, for the report. I think it's always useful to get some independent reviews on things like this from Health Watch Portsmouth. I think overall, although some of the report could be seen in a slightly negative light, I think in some ways there's lots of positives. So when we see 10% of practices hadn't done this, 15% had not provided this, actually the vast majority had, which is obviously a good thing. And I know later in your report you highlight lots of positives as well, which you noted, which is really good. I think I would say over the last 4 or 5 years, the websites have come a long way, certainly compared to what they used to be like. And I know the practices have invested quite a lot of money in those website providers to actually make them as best they can. So they've certainly done a lot of work on it. But having said that, I think the report does highlight a few key areas that we would want to take forward. I'm sure practices would want to look at that. So, for example, you mentioned about the registration requirements. So, yeah, obviously need to get that tidied up where necessary. And I think any areas where access to services wasn't quite clear or anything to do with COVID arrangements, that would be something key to look at. So I'm sure practices will be happy to look at those key issues right now with Health Watch support, maybe involve the PPG if necessary, and obviously you can involve our team as you need to. But I think probably the rest of it is probably more of a long-term thing, given the current climate we're in at the moment. So some of the other issues may be things to pick up further down the line, where we can maybe share good practice, which I know is what you always advocate. But probably something for a bit more further down the line.
Can I just interrupt and say my shopping's arrived, so I'm going to have to disappear for a couple of minutes? Sorry.
Roger did warn us he might be interrupted in that way. He is shielding at the minute, so he has to get his shopping delivered. Dave,
yes, I think just to finish off, I think let's address some of those couple of those really key issues, and then perhaps revisit some of the other ones a bit further down the line when time allows, and our team will be happy to support as necessary.
I think that's really important that we have a follow-up to the feedback, isn't it, so that we seem to take it seriously. I'm not sure there's any point in hearing from Dave. Dave, you were the next I saw as comments and questions.
Yeah, of course, Margaret. I would much prefer that Roger hears what I have to say on the report from a practice manager perspective. So can we sort of wait till Roger comes back and come back to it, please?
Are there any other comments that people want to make?
I was just going to say, Margaret, that obviously some of this is sort of historic, where people previously did have to prove things about identification. I think it's obviously just a case of updating stuff. Stuff is just, people have had websites sometimes for many years that haven't been done. But I would also commend the fact that obviously maybe this is to be addressed to Rogers, that they have actually given some examples of good practice, because I think that is helpful for people to go away and say, okay, well, this is how do what they do. And you'll kind of tick all the boxes. So I think with all of these things, it's helpful to have the guide as to what good looks like, and then you can kind of just go away and enact that rather than just sort of being marked down and going away feeling sort of dejected about it.
Yeah, and I think, and there may be ways that the Health Watch can look at how they present that information in the future. But yes, Roger is now back, so I'm going to take Dave, and then Nick, if you want to then repeat what you just said.
Sorry about that. Thank you.
Okay, that was very quick, Roger. Thanks. Yeah, I have a few comments from a practice manager perspective with the website, and I certainly would echo all of what Steve has said. I'll be honest and say I did feel it to be a negative report. When, as Steve said, quite often it was reading 15% didn't have. Well, actually 85% did have. Just a couple of practicality points on it. In your list of surgeries, you've listed sites. For example, I'm going to use Trafalgar as an example. You've separated Osborne Road Surgery and Eastney Health Centre. Well, the Osborne Road Surgery has not existed since 2016, since the first merger, and I think that's the same for other practices as well, with the Southsea Medical Centre in Devonshire. Practices tend to work on their practice name, i.e. the group name. The other thing to note as well, this was done back in August. With the plethora of information that's coming out, particularly around about COVID, things are changing daily. So it's one of a lot of things that practices have to do with regards to updating information around COVID. So, your points on COVID in there, I think, should be read in consideration with that as well. And my final point is around PCNs. There were some comments about, not too much information around PCNs on individual websites, and I think it is worth noting that, but I think it needs to be sort of considered in context as well. Whilst websites should say which PCN practices belong to, PCNs in a lot of respects are still in their infancy, and they've raced at a very, very quick pace this year around COVID. So to allocate time to put a lot of detail around PCN websites at the moment, I think is probably expecting a little bit too much. But for perhaps something to come, within the next couple of years. But like with everything else, there are some important points in your report, Roger, particularly about the registration, and you're absolutely right about that. Patients do not have to provide proof of address, etc., and those type of things that should be considered. But yeah, like everything, we welcome feedback. But, I would encourage a very light touch at the moment as we go forward, because practices are very busy. And I do know colleagues have put a considerable amount of effort and finance into their websites to get them where they are today. And my final point, a website is only as good as, in some respects, as the person going around it. We've all got great, variations in the amount of IT skills that we've got. So, for somebody who's particularly IT savvy, they'll find it easy to find what they want on a website. But for somebody who's not, then they might find it a little bit difficult. So I think that should be borne in mind as well, that some of the information in your report is probably there anyway. It's just that the person looking couldn't find it.
Sure.
Okay, thank you, Margaret.
I think we did mention that specifically in there. One of the volunteers talked about sort of, tech savvy. I've made a note of your points, Dave. Appreciated. Thank you. And for Steve as well. Any other comments?
Can I come in on that, Margaret? My point was aligned to what some of the points that Dave picked up. Sorry to bounce, Nick. So I must admit, when I went through the report, I had my initial thought when I got to the page of surgeries listed was the same as Dave's, in that there are lots of sites here. And my initial thought was that's probably not fair around assessing some of those sites because they won't be there. But then actually challenged myself around that as if I was a patient, and I know we will get calls into the CCG from patients saying, I'm registered with Osborne Road. So potentially, how do we capture those patients? Now, I'm not expecting every practice to have a website for every site, but if you are a patient, and we've said around the less IT savvy, and we've got a full range of that. If you do put in Osborne Road, is there an easy way of saying, oh, actually, it's not Osborne Road, it's under Trafalgar, or wherever I need to go? And similarly, around the PCNs, I would echo what Dave said, is that they're gaining in maturity, and particularly with COVID is bringing them together to act as organisations, and they are making huge strides forward in that. But again, I don't think patients really get PCNs yet either. So from my point of view, I think there's a definite need to review some of this and to take this forward. See it as a positive light, as Steve said. We're talking, 80–90% of it is correct, rather than potentially 10–15% is wrong. Share that best practice and potentially review it later as a supportive device taking it forward.
Okay, Simon, thank you. I think PCNs are interesting because patients are being sent around to different surgeries, so they're starting to understand it, and I guess it's just some clarity for people, as you know, this is why you're being sent to another surgery.
Yeah, and I think I was having discussions in the CCG 5–6 years ago around how do we get patients to self-direct to the appropriate place. And I don't think in 5 or 6 years we've cracked that one yet, because I think there's still a vast majority of patients think their single point of access to healthcare is to book an appointment with their GP. And we're busting a gut. And as healthcare, particularly in primary care, evolves and we take more care out of hospital into primary care, and we start to move into hubs and PCNs delivering particular healthcare at scale, I think we'll have a challenge on our hands in terms of how do we get that message across. So not only so we get reduce the workload in terms of practices and clinicians, but also make sure that the patients aren't frustrated by being passed around the service as they see it. We need to give them an easy access into the right person at the right time in an efficient way. And I think that's where the PCNs will start to develop in terms of this type of patient-facing comms.
Okay, Joe, I've seen you next, then Dave, then Jackie.
Yeah, I just wanted to echo a lot of what Simon said, really, about how we see this as a positive and the work we need to perhaps do to review that. And I think there's some support we can give the practices, particularly around the PCNs, with working with our comms team and perhaps thinking about some of those elements, the more technical elements that Simon's mentioned around if you click here, what happens. So I think perhaps, and I'm not saying, appreciate that everybody's busy and our comms team are equally busy managing all the messages that are coming down at the moment, but I think we could perhaps start to think about that in the next couple of months as well, working with them on the PCN piece, so that we are making it more accessible and understandable, and working with all of our practices to do that, so that you've got consistency of message.
Okay. Dave?
Just very briefly, Margaret, because I've chatted a lot about this. With regards, the old surgeries, like use the example of Osborne Road surgery, I know from our perspective, what a lot of practices are doing when they change their websites to groups, they are putting a redirect on. So if you type in Osborne Road surgery, it should automatically take you to to Trafalgar. The IT geeks around there will sort of explain that a little bit more technically than what I am. But I think it's simply it's a result of the efficiency of the search engines. And I think 10 years time, if you put in Osborne Road surgery, you would still get something come up for it. So I'm not sure it's an easy fix, but we do try. So we do our best to sort of redirect when we change. Thank you.
Thank you. Jackie.
Thank you. And I would echo a lot of what's been said about how difficult this may be, but it's also lovely to see what it would be like from a patient perspective of people who are just sat down indoors with whatever bit of tech they've got, who are trying to access services and seeing what's out there. So it's good learning for me, certainly, and from what others are saying from the, across primary care. And what I particularly liked about this report is the Appendix 1. So even if practices felt, oh my gosh, this feels a bit overwhelming, it's set out in there areas where you might think about developing, or where patients have maybe struggled to get to a piece of information. So you don't have to eat the whole cake at one time, because clearly practices have done in the majority of cases incredibly well, but you can pinpoint areas for improvement, say, from the report that's set out. And, there's no way you can deny the steps that primary care has taken, particularly in a crisis. But it's particularly in a crisis that we want people to be able to access information.
Okay. Well, any other questions or comments? What I think I've heard is that there's a welcome for this report, that there are issues about how many pressures are on GP practices at the minute, which mean that not all of the recommendations can be taken forward immediately, but a number of them need to be, and that Steve and Healthwatch will liaise about some of that, and think through how we put forward those recommendations and ensure that we get a follow-up that's effective and improves the situation. The other thing I think that has been said is that there might be a presentation issue for Healthwatch in terms of giving more context in future reports and providing a bit more emphasis on some of the positives, so that the report doesn't get rejected just because it's got negatives. Okay, and I think in this case it's not going to be. Okay, thank you very much. If that's a good enough summary, can we then move to flu and vaccination update? And I think it's Simon.
Yeah, I'll update, and I'll ask Steve to chip in around flu at some point. So I was going to try and pull together a report on this, particularly around the COVID, which is obviously incredibly of the moment. But to be honest with you, there was no way that anything that I'd written and shared would have been up to date by the time it landed in your inbox. So this will be a verbal report. Particularly, I'll concentrate on COVID, largely because we've done incredibly well on the flu in advance of the COVID vaccinations. There was a requirement that flu and COVID vaccinations were taken 7 days apart. So there was a push prior to the COVID vaccination programs coming into place to actually push through those flu vaccinations. And I know in discussions and previous reports from Steve that we've done really well in terms of our flu vaccinations across the city, which is a real positive. And that's reflected in the fact that we're doing really well with our COVID vaccination program. So as per the last update, we have the 5 PCN sites up and running for COVID vaccinations. They've all been running through the processes, and it is now a repeatable process that's working very well. We are having no problems in terms of staffing those at the minute. We're having no problems with attendances from patients particularly, or there are some highlights coming through, some reports from PCNs that BAME, particularly BAME care home staff, may not be attending as frequently as the rest of the population, and we are working with comms in terms of how we can try and engage better with that particular cohort of the population to ensure they are being vaccinated. That's not uncommon to us. That is being reported across the whole of the system and wider. So the 5 PCN sites are up and running. There are some frustrations in terms of we were asked to set up a service that potentially could be working 8 till 8, 7 days a week. We are not seeing sufficient vaccine supplies to allow us to function at that sort of level. And I know we are being asked not to share specific numbers in terms of vaccinations delivered, because currently that is we are reliant upon the vaccine deliveries rather than being able to count how many of our over 80s we've vaccinated or care homes we've vaccinated. In terms of those first cohorts, we are on target to achieve that, and we have no concerns of a meeting yesterday in terms of our Portsmouth progress in the first 2 cohorts, and we're starting to move on to cohorts 3 and 4 now. So we have got no concerns, and I think it's probably fair to say that we have used 100% of the vaccine that we've got. There is no delay in vaccinating, and everything's going through. There were concerns through the national programme originally that there might be a degree of waste in the vaccine, particularly with the Pfizer-BioNTech, due to the slightly different way of reconstituting, and that's not come to be. So our wastage is minimal, is in single numbers of vaccines, which isn't unusual compared to any other vaccination programme. In terms of spreading the system wider, we will be having 2 community pharmacies coming online, and they've come through an NHSE approval process. The first one to come online is Lally's in Guildhall Walk, and they are already within the national booking system. So letters are going out to patients to book through Lally's, or go through their GP practice. The option is still there. So we'll start to see those, and practices are already seeing patients saying that they've booked onto a national booking programme. Lally's potentially through the national booking programme can take anybody within a 45-mile radius that wants to go to them. So they are looking at spreading that vaccination site. We will have a second community pharmacy site, but I don't believe I can share that until they've come online. And we will have a vaccination centre within the city. Both of those should be online within a short period of time. So if we were a few weeks down the line, I think they would be up and running. So we're not very far away from those 2 coming online. They will both be working as Lally's are through the national booking service. So at the minute we're showing some really good early adoption within the PCNs. We are ahead of the game compared to everybody else where we can be. Some frustrations in terms of the centres not being able to get as many vaccines as they're able to vaccinate, but that's common across the whole of the country currently. We are having some increasing discussions with PCNs wanting to add in additional sites, so to roll those out to practices, as they have a well-trodden process in terms of their flu vaccination programme, and they would very much like to go back to that type of approach as soon as possible. There have been some changes in the recommendations guidance nationally around going to a second site within a PCN. We are in discussions with PCNs on how to do that, but it is quite strict in terms of setting up a second site. I don't believe, having had an initial read through of the guidance, that we have a site at that point yet where we would gain regional approval to setting up a second site. But I think this is hopefully the early beginnings of being able to go to a practice delivered model rather than a PCN delivered model, because it makes much more sense in terms of being able to have patients vaccinated by practice teams that they know and in a site that they know. So hopefully we'll get back to some sense of normality in a well, some sense of normality is probably overstating it, but a more comfortable state of delivering a vaccination program within practices. So that's the aim. Whether we'll be able to do that in the very near future, I'm not so sure, but that's the aim to get there. Some frustrations that are coming out of the vaccine supply chain is that we don't get notification of a formalised delivery until it can be quite late. And that pushes onto the logistics within the practice in terms of setting up and standing down not only the patients, which can be not an insignificant task, but in terms of the staff as well. So whereas a practice working for a PCN might be trying to stand up a vaccination clinic in the next few days, to be told with a few days notice that the numbers that they were expecting doesn't match the confirmed date, then there has to be a change in some of that processes. And then whereas those staff would have been used on the vaccination program, trying to get them back into a business as usual to handle all the normal everyday core work that GP practices do is then incredibly difficult, and trying to pull patients into any potential opens appointments then isn't a perfect process. So we end up with the potential that we don't have a vaccination service, and then we cannot easily switch back to business as usual, because stepping that up at short notice is difficult. And there are concerns, obviously this has been raised nationally as well, that we are storing up with COVID and patients not wanting to attend practice sites, that there's the potential for healthcare to be put off from the patient's point of view and to delay that. So I think this might be adding to that, and that's the frustrations that the practices are seeing, because they want to get on and do both, but at the minute there are times when they're finding it difficult to do either. But it is getting better. The supply is increasing, and Portsmouth are slowly upping their numbers of patients, and as I said, we are ahead of the wave. So from a Portsmouth perspective, it is frustrating that we can do more, but currently can't due to the tightness of the supply chain, but we are in a good place compared to potentially other sites. I think that's about as comprehensive as I can give you.
Any questions, comments? Right, got a hand up. Claire, sorry.
Hi there, thank you. I just wanted to express really my thanks to both Simon and Steve for all their terrific work in getting, and all the practices clearly, on getting this all up and running in terms of particularly the primary care elements. And just to note as well that in terms of a public health view from the local authority, I'm really grateful for the joint working to give us a city view, if you like, of how things are going, so that we can, link in on, for instance, some of the logistical bits which the council could help with in terms of setting up sites, and obviously giving Helen as the Director of Public Health a city overview too, so that's been really helpful. And certainly we're planning to kind of work together in terms of ensuring the comms messaging, highlighting the issue that Simon's mentioned to reach AIM communities in particular and others, is taken forward jointly. So just really welcome that joint approach, so thank you very much.
Yeah, I think just to echo what Claire said, I think from my early career as a director of primary care, the cross-organisation working has been a real highlight of this, not just within PCNs, but CCGs with individual practices, CCG and council coming much closer together, and being able to actually make the process, which is an incredibly difficult logistical process, to actually get it to this state in, whilst I have described some frustrations, in quite a smooth and a process that hasn't taken an enormous amount of time, and with very few hiccups along the line, I think is a testament to the goodwill of everybody out there, and should be noted that actually we can work together in an incredibly efficient and supportive way.
That's clearly a really positive aspect of what has happened. Can I just ask one question?
Yeah.
And which is that, given what you described as the frustrations in terms of supply, are you confident, is there confidence that the increase in the number of sites will be accompanied by an increase in supply?
No.
So that will dilute what you've got.
So the number of vaccinations, because the current PCN sites have additional capacity and are describing a frequent demand for more vaccines, spreading the vaccines to other sites, and some of the national criteria describe this can only be done to an additional site if there is a specific need that can be identified in terms of patient access to vaccines, etc. Now, given that we are using all of the vaccines that we get, I think that might be a difficult description that we'll be able to describe. I think if you were to look outside of Portsmouth and potentially in a more rural setting, asking patients to travel in the winter X miles to a PCN site when they have a practice site that is capable and proficient at delivering vaccine programs to their local patients, I think there's a different argument in terms of that. But within a city site with we're talking what, 5-6 miles top to the bottom of the island, I think it would be very difficult to describe an inability for a large number of patients to get to a PCN site, given that we're not considering housebound patients, we're considering patients who are able to move, because housebound patients are being met by a I can't remember what they call it now. It's not a wandering service. I can't remember, roaming service. So we will be able to wandering. I know where that came from. So we will be able to reach those patients. This is designed, I think, aimed at more those rural sites where there is a considerable distance to travel for some of those frail patients, particularly at the minute.
Okay. Steve.
Yeah, obviously the main focus is on the COVID vaccinations at the moment. If I can just briefly touch on the flu side of things, because we still have people coming in for their flu vaccinations. There's been a fair bit of activity even over the last 3 or 4 weeks. We're not allowed to actually share or publish the figures until we get to the end of the campaign. But just to say, if we take the over 65s, Portsmouth, we're up at almost 82% now, which is 10 percentage points up on last year, which is great. And for the under 65s in the risk group, we're at just over 55%, and that's about 11% up on the previous year. And finally, for pregnant women, we're at almost 52% uptake, which is a massive increase on last year, where we were about 31%. So yeah, things have gone really well. I'm sure at some point soon, hopefully we'll be able to publish maybe some COVID figures as well.
Thank you. Simon, do you want to come back?
Yeah, just to add to Steve, obviously the social distancing and all of the other prevention aspects in public health that have been put in for COVID will also have a dampening effect on flu transmission as well. So we are hopeful that we don't end up with a double whammy of flu and COVID. And it's worth noting that there is what's the phrase? There is a statutory process by which some of the prescribing decisions are made around antivirals, where there is a national, effectively, firing gun that allows practices to prescribe antivirals to the response of flu symptoms. But that only comes at that national firing line. And we have yet to be told that there is sufficient flu circulating within the system to allow practices to prescribe that. So we are not seeing a normal flu season, is my understanding currently. So I think things are from that aspect are looking quite good in terms of flu.
Okay. Claire.
Sorry, just to make one more point around, Simon picked up on the sort of hands, face, space messaging. Just in terms of the vaccination rollout, just to highlight really that remains critically important, as we all know. But it's a really useful message just to reiterate, of course, to patients and the whole system as the flu vaccination rolls out. Nothing changes in that respect.
Okay. Thank you. Any other comments or questions? No. Can we then move, having noted that update, to the Portstein Group Practice Personal Medical Services contract variation?
Yeah, so this is a new one for me. I don't know whether Carol may tell us she's come across this before later, but Portsmouth Practice hold a PMS contract with the CCG, and there is a clause in the contract which sets out whether they wish to be considered have a health service body status or not. And currently they do have that status, but in writing up a new partnership deed and meeting with their solicitor, they've had advice to change that status. So that's the request that they've put in. So essentially, very broadly speaking, if you're a health service body, you're classed as having an NHS contract, and you have to go down the NHS dispute resolution process for that type of thing. If you're not considered a health service body status, then you've got an option of going down that NHS route or go through the courts. That's kind of my general understanding of it. And I think the key thing that I picked out from the national guidance was that clause 10.4, where it says the contractor can at any time request a variation to this effect, and primary care trusts, so read that for the CCG, shall agree to the variation. So my reading is that they're quite entitled to ask for this. I don't think it makes a material difference to our contracting relationship with them, and as a committee we're kind of just ratifying this. I don't think we really have a decision to make really in terms of whether we agree or not. We're just sort of ratifying it for our contractual purposes.
Okay, Carol?
Yeah, I would agree with Steve. It's an interesting one, isn't it, really? Because to be honest, the only time it actually becomes relevant is if the practice is in dispute with the CCG or the Commissioner, of course. I have to say, I mean, disputes are very rare with general practice, which is a good thing. Most of the time we're able to resolve them sooner rather than later. But I have to say all of the disputes I've known over the years have all gone through the litigation authority. So it's interesting, whatever the status of the practice, there is a tendency to opt to go through that. But that's not to say that practices couldn't choose to not be an NHS body, as it were. Yeah, it's not a problem really, and I don't think it's something the CCG needs to be overly concerned about one way or another. Some practices are and some aren't. The majority are, because they want to just be able to opt into that national litigation process. Obviously it's less expensive for a start probably, but anyway, they do have the choice to go either way.
Okay, Dave?
I read this with curiosity really, and I just wondered, do we know what Portsdown Group's driver is for making the change? Because I agree with everything that Stephen and Carol has said, and it is just merely a curiosity thing, on whether that can be shared or not. So I appreciate it if it can't.
Steve, do you want to respond?
From my point of view, I don't know. I can't really elaborate particularly. I think it was a practice decision. They're going with the advice of the solicitor, essentially. That they couldn't really give me any more than that.
Okay, thank you. Yeah, it's interesting.
Yes, it does sound like it's a solicitor who's wanting maximum flexibility for. I don't know.
Yeah, that's probably about it. Yeah.
Sorry, Nick.
I think Roger was first.
So Roger, do you want to go first?
Oh, thank you, Nick. Very kind of you. I'm just wondering if there's any implications for patients in this, how they complain or any processes. Oh, Carol's shaking her head, so that answers that one. Thank you.
No, it is literally just a case of if the practice gets into a dispute with the Commissioner, then they have a choice of which route they go as to how that's resolved.
Okay.
But it's obviously something we generally avoid, though. We usually manage to resolve disputes before we get to that stage.
Okay, Nick. Sorry.
Mine was just a question, really. Does this align with what all other practices do? Are all the other practices, or is it a mixture of some are?
It's a mixture. I'd say the majority do. So the majority do opt to be NHS bodies, but there are a handful that choose not to. A lot, yeah. I think a lot of them are fairly ambivalent about it one way or another, to be honest.
Well, I guess it just gives you the option. I was just wondering from the CCG's point of view whether we had all in, or whether this means that all are in and have one thing. And I guess until you get to the point where it becomes a problem, you just have a choice or not, as the case may be. So, and you can change it at any point anyway, I guess, can't you? So,
yeah,
I guess it's an academic point. Okay.
Yeah, absolutely. Yeah.
Okay. If there are no other comments, can we move to the next item? We just note this and move to the next item on the agenda, which is the Sequin 2021 and use of funding.
Yeah, thanks, Margaret. I've just turned my camera off because I'm getting a lot of connection problems and failing to pick up words here and there, so apologies for that. But yeah, this is a proposal to use some of the primary care sequin monies for the current year, the current scheme. So a proposal really to use the money for some COVID and work associated with COVID. A couple of key points. The real main aim of the sequin is to help try alternative ways of working, and so I think this proposal would fit in with that. And also we set aside some of the funding to try and see if there's any priorities identified during the course of the year, so we've got the opportunity to kind of respond to any emerging priorities that are emerging priority this year, being COVID. In terms of support that practices have already had, I've just outlined in there for transparency some of the support practices have had. So there's a lot of income protection applied to the QOF, also to the minor surgery, DES, and all of our locally commissioned schemes as well. And actually from early January, we were notified to suspend the majority of our local services unless there was a direct link to the COVID programme or a link to avoiding hospital admissions. But notwithstanding that, even though the income protection applies in a lot of cases, it's not that practices have stopped all that work. There's a bit of a reduction to a degree in some of the activity levels, but in some cases not a massive reduction. A lot of the work has continued. Becky mentioned earlier the COVID expansion fund. So that was some funding to go out to practices, but there were some criteria attached, as you can see in the report. And as we said earlier, we'll be monitoring how that money has been used to progress some of those actions that were outlined. There was also some money made available, some additional money for the PCN clinical director role, which can be used for management purposes as well to help support COVID. And there's also a COVID expenses process where PCNs and practices can claim back for reasonable expenses associated with setting up any new sites, etc. But the one area that we thought just hasn't really been covered adequately is all the work that was mainly done back in the summer around setting up hot sites. So we had practices obviously identifying and prioritising certain sites for COVID, and then making sure that their other sites were effectively cold sites. And then also practices then moved across to doing zoning work as well, so making their practices COVID safe where necessary and having zoning within those sites. So what we've done, we've proposed a new section within the sequin to kind of reflect some of that work. So it's a bit of a reflective piece, but some of the work is ongoing. So it's recognising all the work that practices have done in year and will continue to do. So as I said, I've set out there how this section of the sequin could look. And I think we've also added in there something around peer element relating to peer review work, and we've kind of put that into this COVID section where practices can continue to share good practice. The other thing we could do, we could add another paragraph just to say that any future reasonable COVID activities that are ways of working and workforce, setting up or arranging sites could be covered, going forwards as well, so it's not just a. And we know that one of our neighbouring CCGs with a similar sort of population and profile to us has conducted redirected some of their primary care network scheme monies for this purpose of staffing hot sites and setting up different ways of working. So having talked it through with their director of primary care, I think we would offer some consistency if we were able to use our Sequin monies for to similar effect, really. I think in terms of practice resilience, we know that resources are tight, and also there are lots of other hidden costs that aren't covered by any schemes. This scheme is not intended to really meet those hidden costs, but it would certainly help in some way and ensure that we do secure that practice resilience going forward in terms of both from a financial point of view, but also enabling them to resource things effectively. The kind of rationale for the proposal. I don't know whether Simon wants to come in and add anything or not, and then perhaps go into questions or comments. Simon,
I'd just sort of add from this, so and in discussion with Steve around some of these things, I think the way I'm looking at this is if I had a crystal ball 2 years ago when we were setting up the Sequin and known that there was going to be a worldwide pandemic and we were going to have to be standing all of this up at short notice and the enormous changes that we would have to do, the Sequin would have looked a better version of this. So we would have needed to put in place ways of supporting practices to take on this work and to do it. So this is probably the best that we can do in terms of where we are now. There's a huge amount of work that practices, and I'm sure Dave will reflect that goes into place that can never be accounted for and aligned within a Sequin, particularly when we're being asked to ask on so much goodwill within practices to step up some of this stuff. So this is probably a reflection of all of that, but the best that we can do in hindsight now is my feelings to this.
Okay, I've got Dave and then Carol. So Dave?
I'm just going to be very brief, Margaret. I was really pleased to see this for practices, and I think it will be very much appreciated, because everything that Steve and Simon said for the amount of effort that's gone in, not just at the beginning, but continues to go in now to adapt and work in different ways, is very difficult to cost in practice. So I think this encapsulates a lot of stuff. So I would encourage the committee to support this.
Okay, Carol?
Yeah, I think it's a very good scheme. All I would suggest, and you're probably mindful of this already, is really what is the claiming process going to be like? I know, Steve, you've mentioned around monitoring. I think it needs to be a bit clearer up front what you're what criteria are you looking at in order for practices to be able to claim that payment, really, just so everybody's very clear. And I appreciate it's probably light touch, but it's just very good to be clearer about what expectations are.
Steve, do you want to respond to that?
And it's probably work in progress, I appreciate.
Yes, yeah, absolutely. Yeah, take that on board, Carol. Absolutely. I think that was like a draft section that could be applied to see. We can beef that up a little bit more and set out exactly what is expected. Obviously, a lot of the work has kind of already been done. We're retrospectively catching up with ourselves almost, because we weren't quite sure how things would pan out, whether there would be any money in the Sequin available or whether that could be used for other stuff. Obviously, it's not been able to be utilised for other areas for obvious reasons. So yeah, we can certainly look at that.
Yeah, that sounds good. No, practices don't like surprises at the end of the year, do they?
Lucky.
Thank you. Mine was probably just for my own education and understanding, was the establishment of simple COVID oxymetry at home. Is that something that's begun? Where is it at? It sounds really good, actually. I'm hoping.
Do you want me to come? Yeah, I think COVID oximetry at home service and the virtual ward are two sort of national initiatives that have been we've been asked to set up across the NHS really, and so I really do struggle with saying it properly, so apologies. But the Oximeter at Home monitoring service, we have been working with PCA.
Sorry, Joe, you frozen?
It's admissions for people with COVID who have, need their oximeters monitored, and so that's been operating probably for about 2 or 3 months now. Again, it's a Hampshire and Isle of Wight framework service, but local delivery. So everyone's providing the same sort of thing. And then the virtual ward is the other element of that, which is more around supporting people with discharge. And again, people being able to go home earlier with COVID. So it's really supporting the hospital and helping people to manage at home and monitor them to avoid deterioration. And I have to say that I think, again, it's a huge tribute to our practices and PPCA, how quickly they've been able to get this up and running locally, and the work with colleagues in South East Hampshire and Fareham and Gosport and the Trust to create a single service offer that makes sense, and we have those right pathways. And again, the Hive have been fantastic in supporting this with volunteers to do some of the deliveries around some of the equipment for this as well.
Wow, that sounds amazing, and a credit to everybody, absolutely everybody's involved. And if we get a chance of an update on that, then that'd be wonderful.
Yeah, I'm sure if Mark had been here today, he would have given a much better
update
than my fast track summary. But yeah, we can absolutely do some of that, because I think there are some amazing services that have been stood up really quickly, and the way we've changed things. So maybe that would be useful to bring back or to board, if not.
Okay, can we move then to Carol and then Nick? So Carol first. Carol, I think you're on mute.
Sorry, just a quick comment further to that really is I'd have to say, speaking as a relative of someone who's benefited from the oximetry at home, I think it's fantastic.
Very good.
So it does work.
Nick.
Yeah, just to come in, obviously the evidence on it, just from a clinician point of view, is that if you can pick, people were presenting very late with COVID before, with low oxygen levels, but they weren't feeling as bad as the numbers were, and that was associated with a lot worse outcomes. So the whole point of this was that if you can get people when their numbers are starting to go, but they're still feeling okay, you can get them into hospital, give them the relevant medication, the dexamethasone that you might have heard about, that's been found to be a benefit, and then potentially get them out. And as I said, so there's two elements to this: the bit of watching them before they get in, getting them in early, and then the virtual ward for people to be supported on discharge. So obviously reducing pressure on the hospital, but also supporting primary care, so they're not having to do a lot of this work. It's taken outside of that. Obviously, if somebody needs assistance, they get the GP will probably need to call them if it's a different issue and they're on this. Well, they're not just going to sort everything out, but it's been very valued by practices as well, and very slick and easy to get into. And as I said, real credit to the PPCA for just getting it up and running and getting it going. It's been really impressive, and from a clinician feeding into it, really very good, very much appreciated.
Okay, sounds like a really positive development. We're being asked as a committee if we agree for the primary care sequence 2021 funding to be used in the way described in the paper. Are people happy with that? Can I just see a kind of thumbs up or something? Yeah, or no. Yeah, I'll take silence as acquiescence. Okay, thank you. Can we move then to the next item, which is the overview of the proposed primary care sequence for 21-22.
Thank you. Thanks, Margaret. Okay, so I wanted to just share an overview of the 21-22 scheme with you. I'm not sharing a full draft with you just because it's still very much a work in progress. So I've just tried to pull the main aspects of activity or what we're proposing for the content of the sequence to be. So again, there's a lot of engagement that still needs to take place. The content and the finance aspect of it as well needs to be signed off This will be a 1-year scheme, so it will begin on the 1st of April 2021 and then end 31st of March 2022. And this encompasses both commissioning and prescribing elements as well. So I've been working closely with our medicines management team with regards to building the Sequin programme. So I'll just run through it with you, and then obviously if you've got any questions or anything, please put your hand up. So the engagement programme, we have this in every year, so I haven't really, there's nothing major that's changed here. So we have our commissioning and prescribing events, which, you know, we've always had very good sort of feedback on these. So there'll be 3 of each of those throughout the year. And we have our PCN stakeholder events. We've had a couple of these last year. Obviously things have changed because of the pandemic. And it's just trying to bring those PCN, giving them an opportunity to come together. So we were keen to keep this in the Sequin. Practice visits, again, we have these year on year. Unfortunately, we've had to cancel them this past year just because of what's going on at the moment, the pressures practices are under. We're also going to comprise our quality visits as part of these practice visits. So previously, Steve has done some quality visits with all of our practices, but instead of having to have 2 separate visits every year, which is obviously a lot for the team to do and for practices, we thought we'd combine these. So we're proposing that as well. And then the Practice Managers Advisory Group. So this gives the CCG an opportunity to make sure we're engaging with our practices and we're having those discussions about certain aspects. So, for example, we may take the Sequin there just to have more of an in-depth conversation with our colleagues. Okay, and then I've put sort of estimated total amount around the funding. Again, as I said, it's still very much a draft version, so it's roughly around 32,000 for this aspect of the Sequin. Okay. Right, so the technology programme. So we have one aspect of prescribing sat in here around Optimise RX. And then we have patient online services. So we're always promoting online services, patients to actually sign up to those services as well. So that continues to grow again year on year. Promotion of NHS apps. So again, you know, we have like an NHS app library, so we're always trying to promote those, and they're sort of new apps coming out all of the time. Online consultations, we have seen a huge increase this past year. Practices have been doing an absolute tremendous job around their online consultations, so we want to continue to promote that. There is actually going to be a re-procurement exercise. I think it's in about the spring of this year. So we'd like to get our practices heavily involved with that process and providing sort of feedback on the current provider and piloting other online systems as well. And then just to, I think, revisit their internal processes. Obviously, they've already done quite a lot around this, but because of the sort of impact I think the pandemic's had and the huge increase in online consultations, and we will be asking practices to revisit their internal processes and then just continue to promote online consultations and engage, you know, with their patients on this. Video consultations. Again, this is something that's really just happened this past year, obviously in response to the pandemic. Again, practices have done an absolutely fantastic job taking this on board and adopting new systems. So we would like to carry out some sort of a review on the current provider, how things are going, feedback on that. Also, what about piloting further systems? So, for example, at the moment, we're using AccuRx across the city. TPP, so our clinical system, they actually have a video consultation function. So it may be worth actually having a look at that, because that feeds directly then into their clinical system. And again, because this is something really quite new to practices, I think we need to look at sort of guidelines and developing local guidelines and principles of using video consultations. Is there any support that's required? You know, do staff feel quite comfortable using video consultations? So is there sort of training required? Also for patients, how do patients find it? Is there something we can do there with engagement with our patients? And then again, just internal processes, just to make sure they've got something in place. You know, what is it they have got in place? What works well? What doesn't work so well? Digitalisation of the Lloyd George record. So I know Jason mentioned this earlier. So we were just looking at ways we could support that. So when this pilot site comes on board, is there something else we need to support for that? You know, as part of the sequence. So that's more about sort of, you know, finding out where the practice is at. So a questionnaire, how many records, how many have they already summarised? And also actually the preparation of the records to be collected. You know, they'll have thousands and thousands of records. But that's going to take a long time to prepare those records for collection. So is there something around that we can look at? And then again, our Portsmouth System 1 and Digital User Group. This is a fantastic group. It works really, really well. And this really helps us to develop a lot of the tech going forward that we've been using currently. And also new ways of working within System 1. So internal referrals, task groups, etc. So again, I'd be really, you know, I'd like to include that and to continue to support that group going forward. And then funding, we're looking at around sort of 71,000 for the tech programme of the Sequin. Quality improvement. So we were looking at top-up payments around severe mental illness, physical health checks and the learning disability health checks. So these areas of work sit in other schemes. So obviously we have to be very careful not to be, you know, duplicating any payments for practices. But we actually propose here that we have a top-up payment. So, for example, the SMI, if a practice reaches 60% or above, we can pay them extra payment through the Sequin. And with regards to the LD health checks, if they reach 67% and above, again, we could make this top-up payment for them if they sort of go above and beyond, as it were. And we're also looking, I haven't included it in this paper, but as part of the quality improvement programme around IMS, so MMR shingles, again, to just help sort of promote the uptake of that and what we can do there to support practices going forward. We then have the efficient and effective use of resources. So much of the prescribing elements sit within this section of the Sequin. We then have a section on population health. This will be very much more focused around PCN development, how we can support them around this piece of work, looking more focused at their populations, what's identified within those populations, what's missing, is there any gaps in service. So again, this is quite early days and new to them, so this is why we wanted to put that in the Sequin to help support practices in utilising some of these tools available. This would also help feed in, I think, to some peer reviews. So it's difficult at this point to sort of say, you know we want them to do full peer reviews or audits, but we can't be very sort of specific about what those audits will be, what they will be about. We need to see sort of priorities in the year. So, as I said, some of the fallout from the utilisation of the population health analytical tools may come out of this, or there may be linking in with our commissioning team. So there might be something there that we can get our practices to do. So I can't be very specific in that area. The funding for this section is around 106,000. So yeah, so that's just a rough estimate again for the funding. We then go on to the final section, which is around patient education and community engagement. So our practices, I think I've brought it to the committee previously around the care navigation. Obviously things have changed quite dramatically now for practices running more of a total triage model. So I'd like to revisit care navigation. What does that look like now? Is it still relevant? What are the changes? How we can better support sort of care navigation within the practices? We still have training days available with our training provider, so we're gonna do some more sort of formal training, and then it's sort of engaging as well. It's bringing some of those care navigators together, bringing the practices PCNs together, so some sort of maybe networking group. Again, internal processes, what works well, what doesn't work so well, and getting more of a joint approach with some of the local services. So there's a lot of work at the moment which I'm doing around sort of other community services. So how can we better link up with them as well? So that'll be quite a big programme of work. We then move on to social prescribing. So this is part of the additional roles scheme within the PCN, so they can employ these additional roles within those PCNs. All of our PCNs have social prescribers now. So again, I just want to look at, you know, what is needed on a local level. So very much being fed back to me by our social prescribers is that there needs to be some sort of networking group. We have a ICP networking group, but it's very, you know, it's not localised enough, as it were. So I'm really keen to move that forward and see what we can do, and also linking care navigators into that again. So how can social prescribing link in with care navigation? What could that look like? Identifying training requirements and development. So again, there's loads of training opportunities for them. So you know, what could that look like on a local level? You know, what is out there, what's on offer for our social prescribers? Directory of services. Again, there's lots of directory of services, to be honest, out there. And the conversations I've had so far with our social prescribers, they all seem to be using quite different things. So again, it's actually looking at what is out there and adopting more of a citywide directory. So again, working closely with many of our community providers as well. And then we need to look at social prescribers accepting external referrals. So these are referrals from maybe some of our community nurses, even looking at PHU, whether they can refer into our social prescribers. This is actually a requirement as part of the PCN DES. So this is something we really do need to look at going forward. System 1, how they use System 1. So sharing functionalities within that, how it can be better used across the system. So that's something, again, we're starting to look at now. So, you know, I thought that was good to sit in this aspect of the sequin. And then about how do we measure this? Capture the outcomes, what is good, what, you know, how can we do this best? And again, having a citywide approach to that so we can measure it properly. We then have another element around physical activity. So I've been linking in with some of my colleagues within sort of public health and the council, and this is a huge programme of work now we're trying to take forward. So it's around sort of raising awareness and promotion of physical activity. So this will be offering training. So again, training to sort of our social prescribers in particular, other members of staff as well within the practice. We will look at doing more of clinical training as part of a target. And also about practices being able to sign up and gain active charter status to the RCGP Active Practice Charter. So many of this activity practices are already doing it, but it's about recognising what they're doing. So, you know, so we'd really promote practices signing up to that. Community engagement forum. So again, working with our PPGs, so our patient participation groups. Things have also obviously sort of fallen by the wayside a little this past year. So it's about sort of picking that back up and what work can be done around this. and specifically on a PCN footprint. So what could PPGs look like on a PCN footprint? And many of the activity within the sequin is about patient engagement. So it's getting their involvement more, so I think, in some of these aspects. And ensuring that PCNs have got some sort of patient comms plan. What does that look like? You know, case studies, sharing best practice, etc. So I was really keen to include that. We then have campaign work. So every year we have the National Self-Care Week. Practices have been taking part in that in the past few years. So again, just to continue that. And then a patient campaign. So any sort of campaign of their choice, of the practice's choice. Practices get involved with a number of campaigns throughout the year, to be quite honest. So it's just, again, recognising that. I've also added this patient education events. So Portsmouth University Freshers Fair. This isn't actually for the practices to get involved with. This is just so we can get some funding from the Sequin for the primary care team and our colleagues in the medicines management team to actually engage in the Freshers Fair. So previously we've been along and we've had a stand. Obviously, I'm not sure what it's going to look like this next year, so it might be a virtual Freshers Fair that we could get involved with. So it's just about setting some funding aside to be able to support that piece of work. And then the funding for this section would be around sort of 60,000. And then I've put there the total funding based on all of the above, which I've been through. At the moment stands at around 280,000, but as I said, that's not signed off or anything yet. So I'm just working on this, building that up. With regards to next steps, there's still a lot of sort of engagement that needs to go on with both internal and external stakeholders. I'm still working on the draft sequence, so a lot of the detail I still need to work on. And then obviously we need sort of a final sign off of the content and the funding for the scheme, and making sure our practices are very much involved with that process. And then we need to basically be ready for sign up for the start of the 1st of April 2021. Okay, sorry, I've just sort of rushed through that. So has anybody got any questions or anything?
Thank you very much, Christine. That's really helpful.
Thank you.
Take the questions in order. Nick, Simon, and then Dave.
Yeah, it was not so much of a question, just more comment. I know you've worked extremely hard on this, Chris, and we've had some conversations about trying to evolve this to try and make it as hopefully not a light touch, but as sensible as it can be. And deliverable as it can be with practices, obviously bearing in mind all the challenges and things at the moment. So obviously we want to, obviously, as you say, needs to be engaged with a bit further just to fine tune it. But I think you've done an awful lot of work on it, and the contribution I've made to it hopefully has helped. And hopefully, it's something that we can get agreed and practices to sign up to. The exercise thing, I think, particularly is quite an innovative one that I think will be quite useful.
Yeah, thank you.
And getting the social prescribers a lot more involved as well, definitely, is something which I think is very positive.
Yeah, and I think it's hopefully focusing a lot on what's already going on out there as well. So, we don't know where things are going to be sort of later on in the year, so we've got to be very mindful of that. So it is, it's supporting practices on building up on some of the work that they're already doing as well, and just having that support mechanism there. Thank you.
Simon.
Yeah, just to sort of follow on from what Nick said. So what I've asked Chris to look at as we design this going forward and get into more of the detail is to, rather than perhaps be too directive as a CCG as to the solution, is to have a slightly different look at it in terms of identifying the issue we want to address potentially, and then working with the practices to come up with their solutions. Otherwise, we're trying to fit everybody into a single solution, which given the different demographics and the ways that the different ways of practice working, doesn't always become the most efficient way for every practice. So I think we are going to have a slightly different viewpoint in terms of the sequence this way and how we work practices. That may or may not work, but I think if we don't give it a try, then we'll just carry on doing the same as we've had before, which I think we've got to the point where we've gone into potentially too much detail and need to pull back a little bit. So that was around my thoughts around that. And just to pick up on one of the items with my other hat on in terms of medicines optimization, the managing type 2 diabetes and frailty. We have got maternity leave within the team, and we are working with PHU around a short-term joint post with them with an endocrine pharmacist to work on that particularly, because obviously type 2 diabetes is a big part of primary care, and to give us that support through the year in terms of that specialist support and being able to link in and out with PHU, and to be able to sort of have the blur those edges between primary secondary care in terms of this group. So it will be really interesting to see how that develops, and whether that's something we want to take on longer, or whether we want to look in other areas of high priority in terms of working with practices within PHU. So it'll be interesting to see how that one develops.
Yeah.
Thanks, Margaret. Just a couple of things, and just to echo a couple of the points when you said, Chris, thanks for doing all of this. I know how much thought goes into this each year, and I know practice managers perhaps wait to see what's going to be in the sequin for the next year. Just three main things on the digital side of things. I'm perhaps just a little bit nervous that the system's becoming a bit swamped with different apps, different bits of technology. Yeah. It's been brilliant in the last year, for us to bring a lot of new stuff on, but I just want to sort of, bit of caution going forward in that we don't overdo it, and that's not just from a practice perspective, that's from the patient perspective as well, because we're going to get confused and etc. And I'm sure you will factor that in. You've already mentioned we don't know what the next year is going to look like in times of COVID, and I'm encouraged by that, because we're already close to February, and so we're only 2 months away from the start point of this. So I'm just hoping that there may be some sort of staggered implementation of this year's sequin. And I'll do that for I'll put that forward from a practice perspective. I don't know how easy that is to do, or what your thoughts are around that, but I wouldn't want to see us all of this be sort of pushed out all in one go. And just finally, just to say that I'm really pleased that the practice managers advisory group hasn't been forgotten in the last year, because from a practice manager perspective, I think that's been a real positive of the sequin. To get that early engagement from practice managers, and even even if we can't go back to the old way of doing things, if we can at least do that virtually as we go into the year, I think it would be really beneficial.
Yeah, and Dave, can I just comment with regards to about having a staggered approach to it? And this is very much so. So I know sign up will be for the 1st of April, but the work won't necessarily be starting at that point. So that this will be staggered throughout the year. But we need to keep an eye on how things go and what's happening with regards to the pandemic, etc.
Okay, thank you.
Thank you.
Are there any other comments or questions? Dave, you've got your hand up, is that right? Jackie, do you want to?
Sorry, Margaret, legacy hand.
Jackie?
There was just a quick one, because I appreciate the work that's gone into this again, and hopefully we'll see the draft before it goes out in full.
Yes, I'll share that with you. Yes.
My real question is around the patient education and community engagement, because that's an optional, and I don't know, it was optional last time, I think. Did it get a good take up anyway?
Yes, 100%, to be honest, and I expect that again this year. But we do add that as an optional element, but we always find all of our practices sign up to it.
That's great, thank you.
Okay.
Carol?
Yeah, just to follow up on Dave's comment around staggering the work, which absolutely makes sense, might be worth thinking and agreeing amongst yourselves what is the highest priority pieces of work to do, rather than spread thinly across all of the various pieces of work that's there. Sort of roll it out one thing at a time, or several at a time.
Okay. Thank you.
Okay. Any other comments, questions? Jackie, is your hand up? That's okay.
I see, sorry.
Okay. Can I then try and summarise what the discussion is? In there, I think there's been a sort of comment from Simon, which is about trying to be a bit less detailed in the presentation, not prescribe to the GP practices, but get them to think about what they need to do in order to address those issues. Yes? So that will change some of the presentation of the sequel, I suspect.
Yes.
And we've had some cautionary words from Dave about not overloading with digital apps.
Yes. Yeah.
And about staggering. So I think we agreed on that.
Yeah.
So everybody else is happy with that. Can we just give Chris a heads up to continue the work? Thank you.
Yeah.
Okay, and it will come back to us at a later date.
Yes, yeah, it will do. Thank you.
Thank you very much. Okay, we have any other business that people want to raise? No, nothing. Then can I thank you all for your attendance and apologise a little for the confusion over the risk register at the beginning, but which I think was my fault. Just say the date and time of the next meeting is the 25th of March and at 9:30. So thank you very much. Peter, can Lisa get Peter to turn us our public meeting off?
Yes, I can. Thank you, Margaret.